Auzubillahiminash-shaytanir-rajim. Bismillahir-Rahmanir-Rahim. I am Professor Dr. Sarfraz Hussain Sayyed, Professor of Ophthalmology, Head of I Unit 2, Punjab Medical College, Faisalabad Medical University, Faisalabad, Punjab, Pakistan. We are going to discuss today about the bacterial keratitis. It is uncommon that normal healthy cornea gets infected. It occurs only when normal defense is compromised. But there are some bacteria which can penetrate in apparently normal corneal epithelium. These are Neisseria gonorrhoeae, Neisseria meningitidis, Corynebacterium diphtheriae, and Haemophilus influenza. The pattern of the disease is determined by the virulence of the organism, the anatomic site of infection. Most common pathogens are Pseudomonas aeruginosa, which is ubiquitous gram-negative bacillus that flourishes in soil, vegetations, moist situations in hospital environment. It is a normal commensal of gastrointestinal tract. The other more common are Staph aureus, which is a gram-positive coagulase positive coccus, a commensal of nair, skin, and conjunctiva. Strep pyogenes are gram-positive commensal of throat and vagina. Strep pneumoniae are gram-positive commensal of upper respiratory tract. Pseudomonas aeruginosa and streptococcal infections are often very aggressive. The risk factors in bacterial keratitis are those people they are prone to get more bacterial keratitis who wear contact lenses. The pseudomonas is acquired in 60% cases, and this is because in those patients who wear contact lenses overnight, they have a poor hygiene in lens cleaning and case cleaning, and there is an epithelial damage due to hypoxia and trauma. Bacterial keratitis is suspected in contact lens user with acute painful red eye. Other risk factors in bacterial keratitis are trauma, which may be accidental, surgical, or during refractive surgery, and when there are loose sutures. Also, in cases of agriculture trauma, the bacterial keratitis can occur. It is also more common when there is an ocular surface disease like herpetic keratitis, bullous keratopathy, dry eyes, chronic blepharitis, trichosis, exposure keratopathy, severe allergic eye disease, corneal anesthesia. It is more common in immunosuppressed individuals who are on topical or systemic drugs or having diabetes or vitamin A deficiency. It is more common in patients with measles. The diagnosis is from its clinical features, that is, from the history and also from the signs and from the lab investigations. In history, we should ask for the risk factors already discussed, any history of trauma or contact lens wear or immunosuppression. Patients usually present with the complaint of pain, photophobia, redness, irritation, discharge, and blurred vision. On examination, we see if there are swollen lids and blepharospasm, usually with circumcorneal injection. There is watery or mucopurulent or frank purulent discharge There is corneal epithelial defect and localized infiltrate around the margin and base, which can progress to the large ulcer with severe infiltration. The anterior chamber may reveal a few cells to a large hypopyon. The ulcer near the limbus may be associated with scleritis. The ulcer may progress to perforation and endophthalmitis. Now here you can see there is a small ulcer over there. It can progress to a large ulceration with infiltration, and there may be a progress to even larger one and may have a melting of the cornea, which can lead to a hypopyon formation, which can progress to a perforation and melting of the cornea with endophthalmitis. When there is a corneal ulcer with uh, these appearance like these which we can see in the pictures, then we should also think about the differential diagnosis of a fungal, viral, or necrotic herpes simplex keratitis. They may be associated in cases of marginal keratitis and steroid inflammatory corneal infiltrates associated with contact lens wear. The lab investigations should include taking a sample for smear for the microscopy to transfer the smear to the slides for gram staining. This can be performed with a spatula. Here you can see the spatula, or with a blade of a knife, or sometimes a hypodermic 21 gauge needle may also be used. And then we stain it with the crystal violet. And we can see the different, like the cocci or the bacilli, the gram positive or gram negative, which may be present in the form of the chains, or they may be in a kidney shape present inside the, you can see the bacilli over here, which is extracellular, or they may be appearing as intracellular diplococci in case of the Neisseria infections. We can culture the different culture media are available for different types of culture of microorganisms. For example, the blood agar is for all bacteria and fungi, chocolate agar for the Neisseria, Haemophilus and Moraxella, cooked meat broth for anaerobes, brain heart infusion for aerobics and fungi. The latest investigation is with the PCR, which is polymerase chain reaction. With this, we send the sample for the PCR and we can get the result within 24 to 48 hours. And it has a very good sensitivity and reliability. If there is no response to the treatment, we should stop all the medicines for 24 hours and we should take the samples again. The On the culture, we should also perform a sensitivity test for the bacteria sensitive to different antibiotics. and they will appear as susceptible, intermediate, and resistant. The treatment of bacterial keratitis must be treated aggressively to avoid the progression to perforation and also to have the minimal scarring and opacification of the cornea. General principles for treatment are to first to make a decision which is usually clinical, and the treatment is initiated even before the lab reports. The topical treatment should be started with broad spectrum antibiotics to cover all pathogens, either with two drug regimen as aminoglycosides and cephalosporins. These The cephalosporins have to be prepared because the drops are not available commercially. Or we can start with a monotherapy with fluoroquinolones like ciprofloxacin, ofloxacin, and moxifloxacin. We can make fortified antibiotic drops, which some are available in the market, but most of the time we have to constitute. And these are gentamicin 1.5%, tobramycin 1.5%, cefazolin, cefuroxime, ceftazidime. All these cephalosporin fortified are 5% in concentration, and they are made by the doctors. The topical antibiotics are initially started with 1 hourly for 24 to 48 hours, then 2 hourly during the waking hours for 48 hours, and then 4 times a day until the epithelium heals up. Oral antibiotics are indicated in cases of threatened or actual perforation, when there is peripheral ulcer with scleral extension, in case of the bacteria that can cause potential systemic complications like Neisseria meningitidis. We can also use a subconjunctival antibiotic route when topical are not effective. The antibiotics need to be changed only if the pathogen is resistant to ulcer and is progressing. If the pathogen are resistant and the ulcer is progressing. The cycloplagates or mydriatics like atropine 1% or cyclopentolate 1% are prescribed to reduce the pain by ciliary spasm and prevent the formation of posterior synechiae. The steroids are contraindicated in bacterial, viral, fungal, and acanthamoeba infections. The treatment fails if there is an incorrect diagnosis by inappropriate culture media used, or there is a choice of inappropriate antibiotics, or due to drug toxicity like aminoglycosides and preservatives, and also it can fail in gram negative ulcers because these are usually resistant to the antibiotics. The visual rehabilitation can be achieved by either lamellar keratoplasty by removing the diseased part of the cornea and replacement with it by the healthy corneal tissue. In case when there is a imminent perforation, we can use the rigid contact lenses, and in case of thinning of the cornea, we can also use the rigid contact lenses. The ulcers sometimes may be associated with cataract formation, so we have to perform the cataract surgery for the visual rehabilitation.